Welcome, 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 coders, to the AMCI YouTube course for self-studiers, week 13. Coders, we are more than halfway there. Yes, you can and you will. This week, we're going to discuss urinary male and female systems. And you know what, coders? Pat yourselves on the back. You have made it thus far. And before we go any further, let's go ahead and say hello to the team, the AMCI Dream Team. You know what? They are incredible. And I want to call them out by name if you don't mind. Mr. Sandeep, he's one of our curriculum developers. Miss Dolly, she's one of our, well, she is the MCG editor for 2026, and she's our guideline guru. Miss Bianca, she is AMCI's lead communication person. Okay, I give them titles each week, and when they hear me, they laugh. They're like, "Okay, Miss J. Sorry about person, but you know who you are. You are amazing, Miss Bianca. Miss Meals, she's our intern. She is the behind the success of our intern team. And speaking of interns, let's go ahead and shout out our amazing interns this week in the blue bold. Well, not blue badges, blue badges. Some are light blue, some are darker blue. The darker blue are the lead interns, and I just want to shout them out. They are the bright, hard-working interns. They're learning, and some of them are certified, but they're still learning. You always learn. They're growing and giving back. And you know what, coders? They are happy to do that. All right, so say hello to the team and the interns, and hello to you. We do have a disclaimer. If you're not familiar with CPT coding, we highly recommend that you review our beginners lectures. There are two lectures specifically: CPT Coding for Beginners, Part 1 and Part 2, that break down CPT coding. And I recommend that you begin here, then take this course in order. What's going on at AMCI as it pertains to this YouTube course? We have 3 more weeks. That's it. So it's time to exam prep. Last time I asked you to give me suggestions on schools, courses, material, anything on YouTube that you found helpful so that I could integrate it into the plan. And you know what, coders? You all gave me nothing. No one gave me anything. So come on. And I began looking myself, and this is what I've come up with. Absolutely nothing. You all didn't give me anything. And you know what? We're going to keep going. And I've decided what I'm going to do is feature a certification each week until the 16th week. So today, we're just going to go with what we have. And I like what we already have. But if you know something or I stumble across something else on YouTube that is helpful, trust me, I am going to share it. But this is my recommendation if you are studying for the CPC. After the 16 weeks, you'll need to exam prep. So I recommend that you exam prep the following way. Number one, CHUN your MCG manual. Yes, make sure you have the MCG manual, the FTRs are there. Number two, take all of the practice exams in that MCG manual. That's a lot. Number three, purchase the three AAPs. Well, purchase the AAPC exams, and they come in units of three. So if you purchase the ABC, that's 3 exams. The DEF, that's 3 exams. And it's found on AAPC website. Now, I will put it on your syllabus. So don't think like, oh, can you tell me exactly where to get it? I will have the exact link. But purchase those 3 exams, and pretty much I think you're ready for the CPC. That is my recommendation. Now, if you say, I don't think so, Mrs. J, I need more, then I suggest that you purchase the official CPC certification guide manual or certification guide. Looks like this. And if you say, I need more, I need more, I need to go to boot camp, I need more mock exams, then if you need that, purchase the AMCI CPC exam prep course for $59.99 per month. So you don't need to be in there more than a month or two. So that's what I recommend. I will give you the links and provide these links on your syllabus. And this is the recommendation for exam prep for the CPC certification exam. And keep in mind that these recommendations are only for the CPC exam. I'm going to review CCS-P next week, and the following week, CCS. And then week 16, we are going to talk about additional free resources on the YouTube that you all have found and me. So far, I am still looking, and that week 16, I will unveil what I've come up with. All right. Now, what else is going on with or at AMCI? Well, of course, the AMCI game night. We call it Friday Night Live. And trust me, it is fun, fun, fun. Go ahead, it's in Discord. Go check it out. Fridays at 7:30 p.m. Eastern. So that means it's 6:30 Central and 4:30 p.m. Pacific. Also, I'm TAP. That's interactive medical terminology and anatomy and physiology. And this is on Wednesdays. And you can attend these events in Discord. Speaking of Discord, these are the instructions. They are found on your syllabus on how to join Discord. If you are not a YouTube member, you'll have to become a YouTube member. Click there. After becoming a member, to join our Discord, click here. And yes, this people said that the Discord link expires. This one, if it does, we update this every week. So just know 9 times out of 10, this Discord link on your syllabus is current. After clicking on that link, you'll need to connect your Discord with your YouTube channel. So find your, I guess, your icon or image. And right here, you have this settings or cogwheel. Click on it, then click connections, then locate YouTube, then follow the prompts. And that's it. And if you kind of jumped in on this class, just to let you know, the books, not only for this class, but for weeks 9 through 16, go check out the syllabus on the website www.amcicoding.com/YouTube course. All right, so the books are HCPCS Level 2, CPT 2025. Yes, if you're testing this year, make sure you have CPT 2025. Also, the step-by-step medical coding book. If you want to save money, you can get the 2023, the MCG 2025 edition. If you want to save money, you can get the 2024. All right. And coders, I want to remind you to keep this YouTube course going. Yes, after the 16 weeks, that playlist will still be there. That syllabus will still be there. So tell everyone, tell as many people as you know. For those of you that are doing that, we appreciate you. And to the those people on TikTok, we really see you. We see you mentioning, showing the course. You are incredible. So we thank you. And I just want to let those people that think keeping this all to yourself or gatekeeping is not helpful. This course was developed for everybody. And the more people use it, the more content that we'll likely to make in the future. And by the way, because of the great work that you're doing, we're going to make an announcement during the 16th week, and some of you are going to love it. And thank you. Right. CPT is copyright of 2025 AMA. All rights are reserved. Keyword concept FTR CHUN, AMCI Fab 7, AMCI ICD 10CM Philip TAP, and MCG are registered trademarks of AMCI. CPC, CRC, COC, CPMA, CPB, CPPM, CPCO, and more are owned by AAPC. CCA, CCS, CCS-P, RHIA, RHIT are owned by AHEMA, and AMCI does not own the rights to these credentials. Goals of the presentation for week 13. Number one, we're going to review CPT urinary system, CPT male system, CPT female system, and of course, we're going to do some practice exercises to test your knowledge, and we may have a gem pop up or two. Okay. And finally, we're going to bring you one step closer to CPT coding mastery. Now, let's go ahead and just remind you that these FTRs that we're going to be speaking about, the clippings that you're going to see in this presentation, are going to come from your MCG manual. Many of them are from the 2024, some are from 2025. And if, let's go ahead and take a look at 2025 urinary. From the perspective of the digital MCG or the electronic version, go to your table of contents, click on CPT, surgery, then scroll down until you see urinary, and then one more to come to the urinary FTRs. And the procedure, there are only two procedures that really have guideline nuances. So let's go ahead and review kidney transplants or renal transplantation, code series 50300 through 50380. Number one, there are 6 potential procedures when coding for these transplants. And one thing that you should remember, cadaver kidney removal. Basically, you have 2 types of donors. You have a living donor or a non-living donor, aka cadaver. Just know the difference. And that's pretty much it. Transplantation throughout CPT is pretty streamlined and similar. You need to code for the procedures performed. Also, for additional reconstruction of the donor's kidney before transplantation, beyond backbench work. Backbench work is preparation, but if they have to do reconstruction, for the donor, and I'm often not the cadaver, but the living donor, you have a code series that you'll need to follow or reference. And number 3, code only the procedures performed. So you have to be forensic, and it directs you to use modifier 51 for multiple procedures and modifier 50 for bilateral procedures. This is pertinent to the guidelines. So the guidelines are telling you this. And here's a side note. If you are in the Discord and you come to AMCI's or my sessions on Wednesday, I have a Wednesday lunch for gold and platinum students. If you're MCG, oh, MCDC students, you are platinum. All right. So in that session, I discussed further how to use modifier 51. And I said, now, this isn't going to resonate with everyone, but I did explain it. I created this gem, and the gem is people can't really understand how to use modifier 51 and 59. It's seemingly almost always 59, but we broke this down and we learned how to use this modifier 51 in some when the objective of the procedure is the same, then you use modifier 51. Okay, that might be too much, but I did break it down. And if you have the CHUN lectures, I did break it down there. MCDC, you have it in your course. And Alt Discord Gold, you have it on your playlist. All right, I digress. I'm back now. Finally, the final discussion is scopes, and these vary by anatomical sites. Just follow the general scope rules. Number one, diagnostic scopes are bundled. Generally, we know when it's not bundled. Well, when it's not related, or when that surgical scope, and I'm saying when the procedure is not related, or when the surgical scope is removed, right? So anytime they remove it and do something else, it's often not bundled, but just pay attention to that documentation. When that surgical scope turns into an open procedure, then it's not bundled. And pay attention to separate procedure language, because that means that when you have two scopes and one of the scopes, the diagnostic scope, has separate procedures, then you know it's bundled. That is your clue. And finally, if you have the digital version of the MCG, you'll see these little links here. These links are pretty much, they direct you to the exams and also the videos, so you don't have to flip back. The editor put these in there to be helpful guides. I don't know if they're going to stay because they may be taking up too much time or too much space, but for now they are here. If you see them, just click on them. If not, just go to the top of your index. All right, I'm finished. Let's begin our discussion. All right, time for urinary, male, female. Let's go. And speaking of time, all right, I think we can do this. All right, so in the urinary system, from the table of contents, they are classified by the anatomy. So you start with the kidneys, the ureters, bladder, and the urethra. There you go. Those are all your procedures. And they all look similar. Incision, excision, transplantation, introduction. Those are the most common procedures. And also, the urinary system, you should know the anatomy. On site, you know what the kidneys are. And that yellow or gold color above the kidneys, these are your adrenal glands. They're not mentioned. I don't think they're a part of the urinary system. I think they're more a part of the endo, but it's there. Also, you have your ureters or your tubes, followed by your bladder. And then the male system has the prostate, and both have the urethra. So the anatomy is pretty similar for males and females, but I do want to point out that cysto is often used in urinary system coding. Cysto is another word for bladder. And when you think about a cyst can have fluid. It's a sac with fluid in it. And I can't think of any other sac on our body that has as much fluid as a bladder. So I don't forget that. All right, you ready? You are ready for coding exercises. Really no guidelines, just code it. Use your forensic skills. All right, a hemostat. Oh, no, we're going to just, what code should be used for this procedure? A, 57288, B, 57287, C, 52000, and 57288, D, 52000, 51992. A 67-year-old female having urinary incontinence with intrinsic sphincter deficiency is having a cystoscopy performed with the placement of a sling. An incision was made over the mid-urethra, dissected laterally to urethropelvic ligament. Cystoscopy revealed no penetration of the bladder. The edges of the sling were weaved around the junction of the urethra and brought up to the suprapubic incision. A hemostat was then placed between the sling and the urethra, ensuring no tension. Okay, coders, it says you have 1.5 minutes and your time begins now. Okay, you are on fire. I see a lot of aha moments, and I also see some outstandings in the chat. Here are my keywords: urinary incontinence, intrinsic sphincter deficiency. We have a cystoscopy, placement of a sling, and then they're describing the procedure here. This incision was made over mid-urethra, dissected laterally to the urethropelvic ligament. All right, the edges of the sling were weaved, and then a suprapubic incision was carried out. A hemostat was in place between the slings. So all of that doesn't need to be documented. What we need to document are urinary incontinence, intrinsic sphincter deficiency. Those are the diagnoses. Then we're going to code for a cystoscopy and the placement of a sling, a bladder sling, right? So essentially, on the left is the procedure. On the right, they insert the cystoscope and carry out the bladder sling procedure. And as you can see, they're going into the urethra to carry out the procedure. So we just need to focus on the bladder sling placement and the cystoscopy. All right, good deal. Someone said, wait a minute. All right, so let's go ahead and code it. And we're going to start with C and D. And we see that it's coming up wrong. And the reason it's wrong, if you look at 52000, this is the code for cystourethropy, separate procedure. Anytime you see separate procedure, then that code You don't really have to think about it if that's the only procedure. But when you see a separate procedure, it should be coded separately. However, separately with no problem. However, if it's in the setting of another more complex procedure and it's related, you do not code it. But if it's in the setting of an unrelated procedure, you code it and you append modifier 59. So on site, you know that you can eliminate C and D because number one, they are related, and number two, so you shouldn't code them, or number two, if they are not related, your 592000 should have a 59 modifier appended. I'm looking in the chat. That's right, it needed that modifier if it's not related, but they are related. We saw that they needed that scope to carry out the procedure. So C and D are incorrect. They should not be coded with any other related procedure. And if it is, you need a 59 modifier. If it's not related, then you need a 59 modifier. All right, now we have two codes to look at. We have 57287 and 8887 is coming up wrong because this is the code for removal or revision of a sling for stress incontinence. We're not removing or revising this sling. We are implanting this sling. We are placing this sling. So 57287 is wrong, and 57288, this is the code for sling operation for stress incontinence. And we have urinary incontinence. That's what stress incontinence means. And if you said A, way to go. But if you learned something, that is priceless. Yes, yes, yes. Somebody said, hey, they got separate procedure now. That's what I'm talking about. And not only did I see that you got it, I see that you applied it too. She said, it doesn't have modifier 59. Way to go. All right. So yeah, I do want to tell you that. If a code is separate procedure, now this is a little tip when you're testing. If a code says separate procedure and it is coded with another procedure, that separate procedure code has to have modifier 59. So that's your clue when you're taking a multiple choice exam. I'm gonna let that marinate. When you're taking a multiple choice exam, if one of the codes is separate procedure, and it's being coded with another procedure, it must have modifier 59. All right, that's just a technique. Okay. Now, I think we have time for another scenario. I think we need one. And this time I'm going to ask Mr. Sandeep to take it away, please, and thank you.
Thank you, Mrs. J. Alright, coders, you all have been doing a great job so far, and I am genuinely impressed by the way you are answering these scenarios. I have got few more scenarios lined up for you, so let's do this. Of the following answers, which best describes the encounter? Your options are option A 50365 50323 with 51 modifier, 50320 with a 51 modifier. Option B 50365 50325 with a 51 modifier. Option C 50360 50320 with a 51 modifier, 50325 with a 51 modifier, 50360 50547 with a 51 modifier, 50325 with a 51 modifier. A 55-year-old patient with the end-stage renal disease has been on dialysis for past 3 years. The patient's sibling, a compatible and willing donor, has been evaluated and cleared to donate one of their kidneys. Both the recipient and donor undergo surgery at the same time in the adjacent operating rooms. Laparoscopic nephrectomy and backbench work were carried out on the donor. The extracted kidney is then immediately prepared and transplanted into the recipient through incision in the recipient's lower abdomen. Both surgeries were successful and the patient and donor begins their respective recovery process. Of the following answers, which best describes the encounter? So your time begins now. All the best, coders. Outstanding job, coders. Great answers in the chat. Great. So let's go ahead and solve this scenario. Okay, let's first look into the diagnosis inventory. We have a patient with end-stage renal disease, and procedure inventory. We have a laparoscopic nephrectomy and backbench work done for the donor, and there was an extracted kidney preparation and extracted kidney transplantation performed as well. So these are our FTRs for the kidney transplantation procedure. The codes are ranging from 50300 to 50380, and there are 6 potential procedures. You can have a cadaver kidney removal, living donor kidney removal, backbench work for a cadaver kidney, backbench work for a living donor kidney, and allotransplantation. So there are 6 potential procedures, and for additional reconstruction of the donor kidney before the transplantation, you can refer the code 50327 to 50329. Code only the procedure performed. You can use 51 modifier for multiple procedures and 50 modifier for the bilateral procedures. So with that said, let's look into the option A and option B, which is coding for CPT code 50365. Now 50365 is for a renal allotransplantation, implantation of the graft with recipient nephrectomy. Okay, Curtis, now let me know in the chat. Was there any recipient nephrectomy performed in our scenario? What do you say? Yes, there was a nephrectomy performed. And that was not for a recipient, that was for the donor, right? That's what we have in our procedure inventory, a laparoscopic nephrectomy for the donor, and a recipient nephrectomy was not performed, which means CPT code 50365 is incorrect. And with that, I can eliminate option A and option B because that was not performed here. So we are left with option C and D, which is coding for CPT 50360. So 50360 is for a renal allotransplantation, implantation of the graft without recipient nephrectomy. Okay, that's a good code. It is coding for allotransplantation procedure. Okay, now let's look into the next one. So next, the CPT code 50320, which is in option C, is coding for a donor nephrectomy, including cold preservation, open from living donor. Now, Curtis, my question is, did we had an open nephrectomy? No, right? The CPT code 50320 is for an open nephrectomy procedure, while we had a laparoscopic nephrectomy performed. So CPT code 50320 is also a wrong code selection, and 50547, which is coding for a laparoscopy surgical donor nephrectomy from living donor. So that is the correct code which we are looking for. Yes. And the final code would be 50325, which is for a backbench standard preparation of a living donor renal allograft prior to the transplantation, including the dissection and removal of perinephric fat and preparation of the ureters, renal veins, and renal arteries, ligation of the branches as necessary. So that is coding for the all backbench work or backbench preparation performed. So we have our three procedures here in three CPT codes, and the correct answer, as most of you have said, is option D, 50360, 50547 with a 51 modifier, 50325 with a 51 modifier. Excellent job.
And we're going to talk about the male and female genital system. And just like the urinary system, the male system is pretty straightforward too. But the anatomy is just pretty straightforward. You've got your bladder, the pubic bone, the vas deferens, your urethra, testicle, scrotum, your seminal vesicles, the rectum and anus, prostate, epididymis. So the male system is pretty straightforward. And so too is their table of contents. You've got your penis, testis, epididymis, tunica vaginalis, scrotum, vas deferens, spermatic cord, seminal vesicles, and prostate. And the procedures are pretty standard. Incision, excision, repair. Those are pretty standard throughout. Now, are you ready for a coding exercise? I am. I know you can do this. Okay, here we go. The physician uses a clamp with regional block. A. 51460 with a 63 modifier, B 54150 with a 52 modifier, C 54150 with a 63 modifier, and D 54150. A 4-week-old infant born with undescended testes and phimosis arrives at the pediatric urologist's office for circumcision. Okay, coders, you have 1.5 minutes. Your time begins now. Okay, how did you do? So we've got to do what we're supposed to do, and we're going to highlight our key terms. 4-week-old, undescended testes, circumcision, clamp, regional block. All right. Now this is my inventory. 4 weeks old, undescended testes and phimosis, circumcision, clamp, and ring block. Now I have an image for you. Correction, I have a few images for you. Just so you know, this image here on the left, let me get my pointer. This shows an image of undescended testicles, meaning the testicles are elevated somewhere, either in the abdominal region. These are common places that testicles, when they don't fall into the scrotum, they could be, we refer to it as undescended. So they could be in the abdominal region. Testicles can be in the inguinal region or the prescrotal region. The proper place, of course, is here in the scrotum. All right, so this baby has undescended testes. Now, we're not coding for any procedure for the testicles. We're only coding for the circumcision, right? So let's figure out what took place. Well, the physician used a clamp, but first administered a regional block. All right. So just so you know, this is a ring block. That means the anesthesia was administered around the surgical site. But our case, the patient had A regional block. Just stay right in the middle. They had a regional block, and a regional block is synonymous with a dorsal penile nerve block. So you see in this region, you have your penile nerves. This is the area that was anesthetized. And then the clamp was placed and the skin was removed. Now, let's get back and let's code this procedure. Remember, this is what we're coding for. The dorsal penile nerve block, aka regional block, they mean the same, and the clamp. All right, let's begin. Let's start with 54160. It's coming up wrong, and it's coming up wrong because this is the code for circumcision, surgical, excision, other than clamp. So they didn't use the clamp. They excised the skin. So 54160 is incorrect. And we have left 54150. And these modifiers are going to tell us what is correct or incorrect. All right, so let's go up and look at 54150. Circumcision using a clamp. We had a clamp. Or other device with regional, dorsal, penile, or ring block. Indeed, regional block and dorsal penile block are the same, one and the same. All right, so we know this did take place. However, it's going to be these parenthetical guidelines that drive us to the answer. The first one says, do not report modifier 63 in conjunction with 54150. So if we look at C, it's doing just that. So we got to get rid of C. And now our attention is focused only on B and D. B has modifier 52 and D does not. So now let's look at the next parenthetical guideline. It says report 54150 with modifier 52 when performed without a dorsal penile or ring block. OMG. Coders, this is our case. Excuse me, this is not our case. We do not append a modifier 52 because our procedure was performed with a dorsal penile block. Because remember, dorsal penile is the same as a regional block. Yes, we had a regional block. So B is incorrect and D is our answer. And don't forget these FTRs use modifier 52 without the dorsal penile nerve block. And dorsal penile is synonymous with regional. They are one and the same. Hopefully that's an aha moment. And if you said D, outstanding. All right. So, how would Dr. David report his services for this procedure? A, 54000 modifier, 5416051 modifier, B, 5400163 modifier, 5416051 modifier, 54001 52 modifier, and D54160. A newborn baby boy underwent a procedure to slit the prepuce to relieve constriction that prevented retraction of the foreskin over the head of the penis. Next, A circumcision was carried out via surgical excision. The slit tissue was sutured at the divided skin to control bleeding. The patient tolerated the procedure well. All right, so how would we report, Dr. David? Your time begins now. All right, you all got it. You got it. Let's go ahead and solve. Our keywords: newborn, slit the prepuce, constriction of the foreskin, head of the penis, circumcision, surgical excision, sutured. All right, so we've got newborn, slit prepuce, constriction of foreskin, circumcision, surgical excision. All right, I'm letting a few more come through. Good job, everyone. Good try. All right, so if we look right here in this image, this is what took place. This is an uncircumcised penis. And if you look at the prepuce, what the doctor did was slit it, then suture it back. And this is pretty much like, and then for a circumcision, you retract the skin, right? The skin is retracted. So I'm no doctor, but something seems a little redundant. Don't you think? Well, I'm no doctor, I'm a coder, so I'm going to rely on my codes to help me. But essentially, we're going to code for this circumcision, the surgical excision, and that slit prepuce if we need to. And just as I suspected, 54000, slitting of prepuce, dorsal or lateral, separate procedure. Yes, this should be coded by itself. Mm, mm, mm. We can eliminate everything just based on that. Also, if you look at the child code, the indented code of the parent, 54001, this too is a separate procedure because it's this separate procedure language is before the semicolon. So they share the shared language, the common language portion is shared. So not only 54000 is a separate procedure, so too is 54001, and the chat is raining. Yes. All right. So slitting of that prepuce did take place, but it says do not report this with modifier 63. So A is coding it with modifier 63, and A is also coding it with another procedure. In 54001, except newborns. This is wrong because 54000 is for newborns. 54001 is not newborns. So 54001 is wrong on many levels. Wrong age, the fact that it's a separate procedure and it's being coded with another procedure, related procedure, and they're using modifier 63. So we're going to get rid of B. You are a distraction. C, 2 is a distraction because it's coding only for the slitting of the prepuce and not coding for the circumcision. And that circumcision is more complex than the slitting of the prepuce. So we got rid of C. Now, 54160, this is the code for circumcision. Surgical excision. Yeah. Other than clamp, device, or dorsal slit. So no clamp, no device, no dorsal slit. And it says do not report with modifier 63 in conjunction with 5160. That's not our case. We like this code. And we're getting rid of A because they are coding this circumcision with a separate procedure, which is related. They are related and also sequenced wrong. Your more complex should be sequenced first. And we only had a circumcision to code for. And parenthetical guidelines do drive the answer. They did because they, hey, you can't use that modifier 63. So we got rid of that, and also forensic reading. All right, coders. How you doing? I got one more thing to say. One more scenario. You all ready? You all ready? All right. Someone said, let's get it. Ready. Someone said they're doing pretty good. That's good. Ready, ready, ready. So, since many students have problems with circumcisions, they just do, I'm going to invite Mr. Sandeep to do another demonstration just to kind of make sure we drive it home. If nothing else, by the end of this class, this session, you all should have a much better understanding of how to code circumcisions. Okay, Mr. Sandeep, please and thank you.
Of the following answers, which best describe the encounter? Option A 54161, option B 54160, option C 54150 with a 52 modifier, option D 54150. A newborn male 3 days old is scheduled for a circumcision before being discharged from the hospital. The procedure is performed using Comco clamp. This method involves placing a clamp on the foreskin to minimize the bleeding while the excess skin is excised. The circumcision is carried out without complication and newborn tolerates the procedure well. Of the following answers, which best describe the encounter? Encoders, your time to answer this question begins now. You didn't need it that time. Yes. Okay, coders. So let's go ahead and solve the scenario. So let's look into the procedure and diagnosis inventory. So in diagnosis inventory, we have a newborn circumcision and the procedure inventory. Patient is here for a circumcision and that's a procedure performed. So these are the FTRs for the circumcision procedure. The CPT code 54150 should be used when circumcision is performed using a clamp or another device with nerve block. And the CPT code 54160 can be used for circumcision for neonates without clamp or device. We have CPT 54163 for revision of circumcision. So 52 modifier is used if circumcision is performed without nerve block. Regional block includes the dorsal, penile, or ring nerve block. And in our scenario, the CPT code 54160 is for a surgical circumcision. Same goes with 54161. Only difference is that 54160 is for surgical excision or surgical circumcision other than clamp or device or dorsal slit for neonates, that is the patients whose age is 28 days or less, and 54161 is for a surgical circumcision for the patients who's older than 28 days of age. So these both codes are incorrect because we are not coding for a surgical circumcision and was clearly documented in our scenario that a Gomco clamp was used to perform the circumcision. So yes, we have a clamp used. That means this is not a surgical circumcision, and CPT 54160 and 54161 is incorrect. Okay, now let's look into the remaining option C and D. Both are coding for the same CPT code 54150, which is for a circumcision using clamp or other device with regional, dorsal, penile, or ring block. So as we discussed before, when a circumcision is performed using the clamp without a dorsal penile or ring block, you have to use a modifier 52. So that is exactly what said in our FTR as well. So did we have any ring block used or dorsal penile block used in our scenario? No, right? I can't see such language in our scenario. That means we have to append a 52 modifier with CPT code 54150, and option C is the correct answer. Wonderful, wonderful, wonderful job, coders.
I agree, Mr. Sandeep. That was wonderful. And I think I should drop a gem. And if you don't remember, a gem is a bite sized nugget of truth. All right, you just keep it in your pocket when coding. Very quickly, I want to review when coding 54150 circumcision. This is the code you use when using a clamp or other device to carry out the circumcision. So it typically involves two processes. Number one, the anesthesia. Often they're injecting lidocaine or some kind of anesthetic, either dorsal penile block, or ring block around the penis. And then the second procedure involves the clamp. And the most common clamps are the Gomco clamp, as demonstrated in Mr. Sandeep's scenario, the Mogen clamp, and the Plastibell. So first they administer the anesthesia, then they carry out the circumcision. Now here's the gem. So here is the gem. The gem is that you append modifier 52 to 54150 when no dorsal penile block or ring block was administered. That's it. So they may do something topical, but if the block is not administered, just append 52 with 54150. Okay, so hopefully that gem resonates, and let's continue.
Now we're going to talk about the female genital system, code series 56405 60699. All right, so I don't think there are a lot of procedures in the female genital system either. We've got in the table of contents, we've got vulva, procedures on the vulva, perineum, and introitus. We have vaginal procedures, cervix uteri, corpus uteri. We also have oviduct or ovary procedures, ovary, and in vitro fertilization. And then we've got maternity care and delivery codes. And then the endocrine system has been kind of, it's a part of the endocrine system, but they house the codes in the female genital system. And Mr. Sandeep is going to talk about that. But not a lot of procedures. But I think the most important thing that you need to know when you are coding for these deliveries, you should understand this total maternity package. And the total maternity package includes antepartum visits, prenatal visits. It includes the delivery and postpartum visits. So when a baby is born, the doctor submits the code if the doctor carried out all three, the prenatal, postnatal, and the delivery. The doctor gets to bill the total package code. So the total package for vaginal deliveries is 59400, and the total package for cesarean delivery is 59510. But let's take a look at these codes. So we know there's a total package, but also there are circumstances where a doctor does not carry out all. So you've got specific codes for each service. You have a code for when the doctor carried out a vaginal delivery only. Let's say you're on vacation, the patient's on vacation, and she goes into labor and goes to the nearest hospital. That doctor that carries out that delivery is going to use this code and only this code because that doctor didn't provide the prenatal and more than likely won't provide the postnatal either, or the postpartum. Also, we have antepartum, which are your prenatal visits. So if one doctor only carried out the prenatal, there are the codes here. If a doctor carried out only postpartum care, it has its own codes as well. And look at this separate procedure. That's right. If the doctor did a procedure with it, then you don't code it. All right, if the same doctor. Okay. All right, so we have total maternity package for the cesarean deliver 59510. Got their package. And they also have their cesarean codes, and they also have postpartum care code. And if a hysterectomy is carried out, and it tells you can use this with your cesarean codes. And 59514, yeah. Okay. These are your total packages. Now, are you ready for a coding exercise? What is or are the CPT codes reported for this service? Sorry about my inventory. I think I'm going to leave it here. No, I'll do it. All right, so what are the CPT codes reported for this service? A 59400, 59510 with a 51 modifier. B 59400, 59409 with a 51 modifier. C 59510 and D 59510 and 59409 51 modifier. You know what? I don't like that modifier. I don't. I don't like the modifier. I'm going to change it. All right, coders, I'm going to change it. But when you take your exam, you choose the best one. All right. So I'm changing it on this first one, but it won't change on the second. But just know I changed it. All right. Go ahead. Your time begins now. All right. You all are doing amazing. All right. Good job. Let's go ahead and let's highlight our key terms. We have a 27-year-old woman who delivers twins by her regular obstetrician. The first is delivered vaginally, and the second is delivered via C-section. Both are delivered without complications, and the patient will return in 2 weeks for postpartum visit. All right, coders. We talked about this surgical package. Can we use a surgical package? Did one physician carry out all three? Yeah. Yes, it said this is her regular obstetrician. So obviously he's carrying out the prenatal. So we might be able to use one of those codes, right? Those package codes. And let's look at the guideline for total maternity package. We have a vaginal total package and a C-section total package. And we got to know, is this a vaginal delivery or a C-section delivery, right? But answer this question. Here's a coding tip. It says total package includes prenatal visits, delivery, surgery, and post-op natal care if used. If one doctor performed all services. Okay, so you have a doctor who carried out prenatal visits for twins. Do we use two total packages? Yes or no? Oh, we wouldn't, because even though you have two different methods of delivery, I don't think she went in for two different visits for each infant. So just saying. So we would probably code one total package and one delivery. Not probably. That's what we would do, right? So which one would we sequence first? I'm just having an adult conversation with you all. Would you sequence, which total package would you use? Would it be the vaginal or the cesarean? That's right. Somebody said the most complex. Indeed, what's more complex? The vaginal delivery or the cesarean? Absolutely, the cesarean, right? All right, so we got two total packages. If we have twins and one is delivered cesarean and the other vaginally, absolutely. We're going to grab that cesarean delivery total package. So we're going to eliminate A and B. And the reason why we're eliminating B, because B is not only coding for the vaginal delivery total package, but also a vaginal delivery additionally. So B has to go because that's not what happened. And if we look at what remains, C is eliminated because it's only coding for the total package. And D is coding for the total package and the vaginal delivery. And you know why I want to change that modifier? I want to change that modifier because these are two different procedures. They are not the same procedure. So if it's wrong, I can't sit here and teach it. I know. Somebody's probably saying, you just should have left that alone. You didn't, you gave us the answer, Mrs. J. I probably did. But I want you to know that if you were coding this on your own, make sure that this is a modifier 59, two different procedures. And don't forget about that coding tip. And also, if you want to document yourself what we've discussed today, if you have delivery, two different births, one total package for the two different types of birth, sequence first your cesarean, followed by the vaginal delivery. All right, let me see how much time we have. I think I do have time. How many? Yeah, I think I have time for this short one. And then I'm going to hand it over to Mr. Sandeep. And this is really short. All right. There's no question. So A, 58120, B, 59160, C, 57800, and D, 57700. What code should be reported for a diagnostic dilation and curettage for a patient experiencing heavy bleeding that is not associated with pregnancy? All right, coders, what say you? Your time begins now. You all are rocking it. I'm sorry I'm starting a little earlier, but I want to get Mr. Sandeep enough time to talk about his subject. All right, so our keywords. We have a diagnostic dilation and curettage, heavy bleeding, and it's not associated with pregnancy. We don't have a guideline. We can go ahead and code it out. 57700, this is cartilage of uterine cervix, non-obstetrical. This is not the procedure. You could easily mistake the two, but one is curettage or a DNC. Okay, this is a cerclage. Sorry about that from the mispronunciation. And 57800, and also too, this is a repair. All right, we're not doing that. All right, so we have manipulation, 57800, dilation of cervical canal, instrumental. I don't know if that took place either. Okay, it wasn't manipulated. And then 58120, this is dilation and curettage, diagnostic and or therapeutic, non-obstetrical. This is indeed our answer. All of the keywords in the documentation matches this code, and this is what happened. And then we can look at 59160. This is curettage postpartum. That is associated with pregnancy, and ours is non-obstetrical. So A is our answer. And if you got that correct, outstanding. Good job, everybody. All right, Mr. Sandeep.
Of the following answers, which best describe the encounter? Option A 57320, option B 57330, option C 57310, option D 57300. A patient with vesicovaginal fistula underwent a surgical repair. In the operating room, the patient was positioned in lithotomy and general anesthesia was administered without complication. The perineum and vagina were prepped and draped sterilely. A weighed speculum exposed vaginal vault and methylene blue dye confirmed the fistula location. A Foley catheter was placed for bladder drainage. An incision was made and fistula margins were excised. The bladder and vaginal wall were mobilized and separated. The bladder was repaired in two layers with absorbable sutures, and the vaginal wall was closed separately. Of the following answers, which best describe the encounter? Encoders, your time begins now. You all are rocking in the chat once again. Good job, coders. And we have a diagnosis inventory, vesicovaginal fistula. In procedure inventory, repair of this vesicovaginal fistula was performed. So what is a vesicovaginal fistula? So this is an abnormal connection between the bladder and the vagina, right? So bladder and vagina will be connected. That will lead to an unintended leakage of the urine from the bladder into the vaginal canal. Okay, so CPT code 57300 is coding for closure of a rectovaginal fistula. So that is not condition which we have in our diagnosis inventory. We have a vesicovaginal fistula, not a rectovaginal fistula. So option D, you have to go. 57300 is not coding for the correct procedure. And CPT code 57310, which is option C, it's coding for a closure of urethrovaginal fistula. So once again, there is a difference between vesicovaginal fistula and urethrovaginal fistula. So option C also has to go. We are left with option A and option B. So option B is coding for 57330, which is for closure of a vesicovaginal fistula, transvesical and vaginal approach, while option A 57320 is coding for a closure of vesicovaginal fistula by using vaginal approach only. So in option B 57330, 5730. In this procedure, surgeon will repair the fistula between the bladder and vagina by maybe making an incision in the bladder with an abdominal incision, and he also performs the vaginal part repair by using a vaginal or through vaginal approach. So there are two approach which is used in 57330, and in our scenario we have only one approach, that is vaginal approach. How did I know that? Yes, from this language. You can see a weighted speculum exposed the vaginal wall and a methylene blue dye confirmed the fistula location. So there is no documentation of any abdominal or transvesical approach. So only vaginal approach was used, and that confirms my answer. And the correct answer is going to be option A, 57320. Once again, excellent job, coders. Great answers. Okay, I think I have one more scenario with me. So let's do this. Of the following answers, which best describe the encounter? Option A, 59510, 58150. Option B, 59510, 59525. Option C, 59514, 58150. Option D, 59618, 58150. Dr. Lee provides comprehensive obstetric care to a 35-year-old patient throughout her pregnancy, including regular prenatal visit and monitoring. During the labor, complication arise necessitating an emergency cesarean delivery followed by an unexpected postpartum hemorrhage that doesn't respond to conservative measures. Dr. Lee performs a caesarean hysterectomy to control the bleeding, removing the entire uterus, and continues to provide postpartum care in the weeks following the delivery. Of the following answers, which best describe the encounter, and coders all the best for this scenario? And that is time. So let's go ahead and solve this one. Okay, Coda. So here we have in diagnosis inventory, cesarean delivery, postpartum hemorrhage, and procedure inventory. We have an antepartum care given, cesarean delivery performed, hysterectomy, and postpartum care given as well. So the guidelines, the FDRs are here. We have the CPT code 59510 to 59525. That's coding for a cesarean delivery procedure. And yes, in our scenario, we had a antepartum care, a cesarean delivery, followed by a postpartum care given as well. So we have all the three services given, which means this is a package service, and we have to code for a cesarean delivery package code. So 59510 seems like the correct answer. That is for a routine C-section with the prenatal and postpartum care. But still, let's go ahead and look into the other codes. Option C coding for 59514, which is for cesarean delivery only. So this is incorrect. As I said, we have antepartum care, C-section, and postpartum care given in this scenario. So 59514 you have to go, and 59618 option D is also incorrect because it is coding for a routine obstetric care that includes antepartum cesarean delivery and postpartum following attempted vaginal delivery after previous cesarean delivery. So was this documented? Were there any attempted vaginal delivery for after the previous cesarean delivery documented in our scenario? No, right? No, it was not documented here. If it is not documented, it didn't happen. So option D is also incorrect. Now we are left with option A and B, both coding for 59510 CPT, which is for routine obstetric care, including antepartum, cesarean delivery, and postpartum. So yes, that is a good code selection. That's what happened. And we also have to code one more procedure. You know what? Yes, the hysterectomy procedure code. Okay, so option option A is coding for 58150. That is for a total abdominal hysterectomy with or without removal of the tubes, with or without removal of ovaries. Now you might feel this is a good code selection, but there is a catch. Yes, and you can see it in the FDR. CPT code 59525 is used for a hysterectomy following C-section. Yes, so when a hysterectomy procedure is performed after a C-section, you have to use the add-on code 59525. You can see in the parenthetical notes also it says that 59525 is used in conjunction with 59510, 59514, 59515, 51618, 51620, and 59622. So it is coding for a subtotal or total hysterectomy after cesarean delivery. So whenever a hysterectomy is performed after cesarean delivery, don't forget to give or append this add-on code. So that eliminates option A. Correct answer is going to be option B, 59510, 59525. Once again, great job coders. You all are rocking it. Now it's time to move on to the next system or next chapter, that is going to be the endocrine system. Yes, we are going to discuss about endocrine system, and the code series are from ranging from 60,000 to 60,699. So yes, so we are going to talk about thyroid procedure. So human thyroid gland, it is a butterfly-shaped organ located in the base of the neck, and Chorus, it releases a hormone which is known as thyroid hormones, which control the metabolism. So when coding a thyroid procedure, it is very important to understand the amount of thyroid being removed, because that is key and that is going to drive the procedure code which we are going to select. And we also have parathyroid glands which produce a hormone known as parathyroid hormone, or PTH, and this parathyroid hormone raises the blood calcium level by breaking down the bone where the most body calcium is stored, and it causes the calcium release and increases the body's ability to absorb the calcium from the blood, from the food. So that's about the thyroid gland and parathyroid gland. And next, yes, so you can see in the image the human thyroid, it has a two lobes and an isthmus, and each lobe constitutes one half of the thyroid gland. So it actually looks like a bow tie, and when both the lobes along with isthmus is removed, that is when entire whole bow tie is removed, it is considered to be as a total thyroidectomy. So that is a total thyroidectomy. And now let's move on and let's look into other thyroid excision procedures. So the CPT code 60220 is for a total thyroid lobectomy, unilateral, with or without isthmusectomy. So what happens in this procedure is that one entire lobe on either side, either on the right side or on the left side, one of the lobe is totally removed, completely removed, and that is a total thyroid lobectomy. And the CPT code is 60220. So now let's look into next CPT code, which is 60210, partial thyroid lobectomy, unilateral, with or without isthmusectomy. Now, in this procedure, up to one half of one lobe is removed. That means a quarter of the bow tie is removed. So you can see in the image as well. So up to one half of the one lobe, that will be a partial thyroid lobectomy, and the CPT code would be 60210. Now moving on to the next thyroid excision procedure. Yes, we are going to look at the partial thyroid lobectomy with contralateral. So contralateral means opposite, and the CPT code is 60212, which is for a partial thyroid lobectomy, unilateral, with contralateral subtotal lobectomy, including isthmusectomy. So what happens here is that up to one half of one lobe on one side and up to one half of another lobe on the other side, which is a contralateral side, is removed. So with a total of half of the whole thyroid is removed, which also means that the bow tie or the thyroid was cut in half top to the bottom as opposed to side by side. So the cut is actually made horizontally. So this image will help you to understand what the procedure 60212 is about. And moving on to the next excision procedure, which is a total thyroid lobectomy with contralateral subtotal. So what happens here is the CPT code is 60225, that is for a total thyroid lobectomy with contralateral subtotal lobectomy, including isthmusectomy. So one entire lobe on the one side is removed, and a subtotal lobectomy on the contralateral side is also performed. Subtotal, it's not complete total, it's subtotal lobectomy only performed. So as you can see in the image, it's almost 3 by 4 of the total thyroid is removed in 60225. And finally, total thyroidectomy, as I said in the beginning, it will involve the removal of both the bowels along with the isthmus. So that will be a total thyroidectomy. And the CPT code you bill for is 60240, thyroidectomy total or complete. So these images are very useful in understanding the procedure that is being performed. So you can see 60210 is for partial thyroid lobectomy, unilateral with or without isthmusectomy, and we have CPT code 60212, which is for partial thyroid lobectomy with contralateral subtotal lobectomy, including isthmusectomy, and 60220 is for a total thyroid lobectomy unilateral with or without isthmusectomy, where one complete lobe is removed as shown in the image, and 60225, which is for a total thyroid lobectomy unilateral with contralateral subtotal lobectomy, including isthmusectomy, which removes almost 3 by 4 of the entire thyroid gland, and finally 60240, which is for a thyroidectomy total or complete, which involves removal of entire thyroid gland, that is 2 lobes along with the isthmus, and that is a total thyroidectomy. So I hope these images are helpful for you all. And now, are you ready for a coding exercise on thyroid excision procedures, coder? Yes. So let's do a coding exercise. So I'll read out the answer first. What CPT code is or are reported? Your options are option A 60210, 60225, option B 60225, the 50 modifier, option C 60210 LT, 60210 RT, option D 60212. Under general anesthesia, the provider excised lower one-third portion of the right lobe of the thyroid as well as lower one-third of the left lobe. Isthmus is also removed. What CPT code is or are reported? So coders, I will give you how many times? Let me see. I'll give you 1.5 minutes to solve the scenario and your time starts now. So Ace Alligator is here, and how are you all doing? Yeah, so I see a lot of amazing answers in the chat. So let's highlight the keywords: general anesthesia, thyroid, general anesthesia excites thyroid, lower one-third portion of right lobe, lower one-third portion of the left lobe, isthmus is also removed. And yes, so let's have a quick look into our FTRs, whether a total or partial thyroidectomy performed. It's a partial. With a thyroidectomy or lobectomy performed, it's a lobectomy performed here. The partial lobectomy is up to one half of the lobe. Subtotal is almost total, and contralateral is opposite where horizontal cut is made. So in our scenario, we have a lower one third portion of right lobe removed and lower one third portion of left lobe removed. So it actually looks like the image given below. Can see a horizontal cut which is made, and lower one third of right and lower one third of the left lobe is removed. Now let's look into our code options. Option A is coding for 60210, which is a partial thyroid lobectomy, unilateral with or without isthmusectomy. And 60225 is coding for a total thyroid lobectomy, unilateral with contralateral subtotal lobectomy, including isthmusectomy. So referring with our image coders, do you think it's 60210 which has been performed? No, we had up to yes, we had lower one third of right and lower one third of left thyroid gland removed. And so 60210 is incorrect, and option A is also coding for a 60225, which is almost the total portion, or 3 by 4th of the total thyroid removal. So that is incorrect. That is not what the procedure was performed. So option A is wrong, and option B 60255 is also wrong, as that removes almost 3 by 4. 60255 removes almost 3 by 4th of the thyroid gland. So option P is also incorrect, and option C is coding for 60210 LT, 60210 RT. Well, that code is also wrong, because we have a much more specific code or specific answer in 60212, which is coding for a partial thyroid lobectomy, unilateral with contralateral subtotal lobectomy, including isthmusectomy. Yes. So you can see the image near the 60212 and the image we are having in the lower bottom where the procedure is performed. So yes, these images are very helpful in solving the thyroid excision procedures. So the correct answer is going to be option D, 60212. So let me quickly look into the chat and see how are you doing. So let me know, coders, how are you feeling after this thyroid excision procedure? So have you got it? Yes. So I see a haha moment in the chat. Okay. So feeling good, great, nice to hear.
All right, coders, it's time to close things out, and let's go ahead and see what we reviewed. For week 13, we reviewed the urinary system, male system, female system. We did practice exercises to test your knowledge, and I did give you a gem. Hopefully it's useful, and hopefully you're one step closer to CPT coding mastery. Now, let's quickly review the homework. All right, if this is your first time, make sure you go to our website, www.amcicoding.com, click on YouTube course. When you get to the website, read everything. And if this is your first time, begin with week 1. That is my recommendation. The first 8 weeks is ICD-10-CM instruction, and then the 9th through 16 is CPT. And we're on week 13. So click this red hyperlink to download the syllabus. You'll see the books, all of the required texts for this course. And then time for the homework. Number 1, Download. This is week 13. That's it. All right, week 13, download the class PowerPoint. If you're in Discord, go ahead and find them under resources file or the handouts. Number two, watch week 13 playback if you need to. If you want to watch this playback again, click here. Click the green hyperlink. Number three, do your reading assignment. That's Unit 3, Chapter 20, Carol Buck's Step by Step Urinary and Male Systems. Number four, watch the CHUN lecture on urinary male and female systems. You can access it from your MCG manual. Click on charts, videos, exams, and additional resources. Then scroll down and find that lecture. Right here it says Advanced CPT Instruction 50,000 Series, Urinary Male and Female. Then number five, optional. This is watch the lectures on how to code long scenarios or operative reports. And you just click on the green link. That's your standard playlist. Number six, CHUN, the urinary and male CPT sections of your manual. And if you want some tips on how to do it, we recommend that you join the AMCI Facebook CHUN group. This is where all the students have, not all the students, but some students have placed their CHUN. And the interns have categorized it so you can find it. So essentially, click that link to join the CHUN group. The admins will let you in. And then when you arrive, go to the top and click on Media, then Album, and boom, here are the CHUN pages. And these say from 2023. So this is 2023, but it's still a good reference. Go ahead, check it out. And they are in pretty much in order. No, they're not. Just locate the topic that you're interested in chunning. All right. I do encourage you not to copy verbatim. Make chun your own. At one point, we used to chun people's books for them, but we no longer do that because there is something to be said about creating your own chun. And even our instructors chun. If you're a gold Discord member or platinum Discord member, you will get the instructor's chun, but it is in the format. Well, the instructor who did it was Dr. C, and that's how she chuns. So when you listen to my lectures, the chun lectures, if you are in the chun, if you are gold or platinum, you'll hear me say, these are some adjustments that you can make. It's important that you make chun your own because it works when it is yours. It works best when it's your own. All right, I digress, but I'm back. Numbers 7 and 8. You'll need to complete first the urinary quiz and second the male system quiz in the MCG manual. Make sure you go to your MCG manual, click on charts, videos, exams, click on the link or QR code, find the exams, take them, and you have multiple attempts. You do. Next, number 9. Reading assignment. Now we're going to read Unit 3, Chapter 21. This is Carol Buck's Step by Step Females System. Then number 10. This is an optional watch. Go ahead and watch the operative report, how to code an operative report, female system. So it's not required, but it is, if you want to. Some people just want to know. And also, too, this will help you on the charts select section of the CPC exam. All right. Number 11, go ahead and chun the female section. 12, complete the female system quiz in your MCG manual. And finally, if you need to, or have time, or your hands aren't free, but you want to listen to some coding that's pertinent to what you're studying right now, click on the this purple link. This is the AMCI podcast, and this podcast is specifically for CPT. And be sure to attend the Friday Night Live in Discord, as well as I'm Tap on Wednesday nights. And finally, next time, we will turn our attention to CPT nervous, eye, and anesthesia coding. Okay, coders, just want to say thank you, thank you, thank you, and thank you in advance. Why? Because I'm asking you to complete the survey. The survey's in the chat, it's also pinned. Please and thank you. Let us know how we did. Let us know. How do we improve if we don't know? How do we also too, if you want to encourage us, just give us your thoughts and compliments. We take them. We take them all. And thank you in advance. And finally, please take a moment to like up this lecture if you enjoyed or you got something from this instruction. Like it up, like it up. If you didn't, go ahead, thumbs down. Please and thank you. And thank you. Thank you to my amazing team. I honor you, and I just want to let you know that I appreciate you more than you know. Encoders, thank you. You've done your best. You are lasting. This is the 13th week. Just three more. Now, coders, go study, go practice, and go be great. And I'll see you in the next session.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI. 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 AMCI.